Hi, my name is Ben Schurhamer, urologist here at University of Pennsylvania. Excited to talk to you all today about focal therapy for prostate cancer. It's a newer approach to prostate cancer treatment, and the focus of focal therapy is to get rid of cancer while keeping side effects low. Over the next few slides here, I'll explain what it is and how it might improve treatment outcomes for certain prostate cancer patients. This is just a depiction of a typical clinical scenario. You've likely come to the doctor recently and you've had the chance to sit down with one of us and go over the results. After you go over those results with us, sometimes the patients can be left like this. You're sitting here at the crossroads of multiple decisions. Do I go with radiation therapy? What type of radiation therapy? Do I go with surgery? Which surgeon do I pick? Do I go with focal therapy? What will that do for my anxiety and cancer control down the road? Suffice to say is that, we get it. We get that this is a hard problem. We get that waiting through these options is difficult and taxing. And we see you. And so hopefully this information today can help at least clear up which one of the approaches is, and you can figure out if it's the best approach for you. We know that prostate cancer outcomes for traditional whole gland treatments have been phenomenal. We know that when just looking at cancer treatments, overall outcomes, we know that survival is great, whether you choose surgery or radiation. And we know that the 15-year survival results of those treatment modalities really works. But the question is so if we have two good treatment options, why would we look into something further? And so when we look into focal therapy, the idea is that we treat the tumor, not the entire prostate. We hope to kill the cancer while reducing the damage for the rest of the prostate. And due to advances in MRI and genetic technology, this is an alternative for men who have a defined lesion that's unilateral and want to avoid some of the side effects that come with typical whole gland treatment. And so focal therapy bridges the gap between men who are choosing active surveillance but may not yet be interested in a radical treatment or may not have the disease that would be serious enough to move forward with that. And so focal therapy, or just treating the index lesion in cancer, that idea is not new. This trial looks at a study done back in 2002 that looked at lumpectomy versus mastectomy, so lumpectomy and radiation versus mastectomy for women with breast cancer. And it was pretty revolutionary when the idea came out that instead of leaving the oncologist office with a mastectomy or potential bilateral mastectomy, you could preserve the majority of your tissue by getting a lumpectomy, so just removing the cancer spot, getting surrounding radiation, and could preserve your tissue by choosing this approach. And the important part of that is that the cancer outcomes were equivalent or the same between those. And so can we expand that line of thinking to other cancers? And so much work has been done on this in prostate cancer, and this slide depicts that on the far left of the slide is the traditional pathologic examination, so that's the Gleason score. But on top of the Gleason score, we've been able to layer on other technologies, specifically DNA or genomic technology with advanced genomic assays. And then we've also been able to layer on the MRI technology. And so instead of sort of taking just a single look at the prostate, we're actually now able to see it through three different lenses that help us view the exact disease that's taking place in the body. And so the rationale for focal therapy is that prostate cancer tends to be multifocal. It tends to be that you have multiple little spots of disease. However, the research in the field is leaning towards the idea that the index lesion, or the main tumor, which would be the largest tumor, the one that is typically visible on the MRI, is the one that drives the biology. And by treating the index tumor, you are knocking out the metastatic potential of the disease process. So if we take out the bad actor, that may have the side effect of eliminating the most serious disease in the prostate. And so when we look at focal therapy, there's three main types of energy. There are other emerging focal therapies, and this is not an exhaustive talk on all the different types. But the three ones that have the largest body of research are going to be these three. So these are going to be the ones that I discussed today. And so the bottom one that you see there is A, and that's HIFU, or high intensity focused ultrasound. HIFU works great for posterior lesions, or lesions that are on the bottom of the prostate. Then the other two lesions are B and C, and those are both delivered percutaneously or transperineally. And so those are by needles that are actually driven into the prostate, into the lesion itself. And those typically work better for what we call like anterior lesions, or spots that are on top of the prostate. All of these are mapped with a transrectal ultrasound, similar to what you use when you got the original biopsy. So the first focal therapy method is HIFU. There's a lot of information on this slide. You are more than welcome to pause, read it, and come back to it and read it at a later date. So I won't be reading all the information, but HIFU stands for high intensity focused ultrasound. It uses sound waves at a very high frequency that you can't hear, and these sound waves are concentrated and focused on the prostate tumor to actually heat it up and destroy the tissue cells. It's done by inserting a probe into the rectum, like when you got the original biopsy, and that can focus sound energy on the exact area of the cancer. HIFU is minimally invasive, meaning there's no incisions on your body, and it's done under anesthesia, and you go home the same day with a Foley catheter for 3 days. The idea between HIFU is that we treat just the tumor itself with a small safety margin around it, not the entire prostate. And so when we bring a patient into the operating room, we put the transrectal ultrasound probe into the rectum. We map out the lesion using a combination of MRI and ultrasound technology, and then ablate or kill the cancer cells in that area using heat. The HIFU energy does not heat at distances close to the probe, and so therefore it's really able to transverse where it's supposed to go and heat up specific 3 millimeter sections of the prostate. We typically use multiple ablation zones, but if you're a candidate for this, we would consider either what's called a single quadrant ablation or a hemiablation. So we're just ablating ideally a smaller part of the prostate. The next technology is IRE. IRE also stands for irreversible electroporation. This is a transperineal delivered technology, and instead of using heating or freezing, the transperineal delivered electronic waves, or we'd say like short, high voltage electrical pulses, poke holes in the membranes of the cells. Those holes allow for different, for the cellular contents to evacuate, and thus kills the cells and also has the side effect of preserving antigens for your body to come and clean those up. The last technology is cryotherapy that I'm going to discuss today. Cryotherapy is opposite of HIFU. Cryotherapy actually uses a freezing technology. It's delivered similar to how the IRE is performed. The benefit of cryotherapy is that cryotherapy has been used for many, many years for salvage treatment after radiation. So if the radiation didn't take the first time, cryotherapy is typically used after that. And so when we look at outcomes of focal therapy, the majority of the outcomes that you'll find in this field are really kind of in the 5-year point of view, and sometimes we'll expand up to 10 to 15 years. But the general outcome is that for most men, at 5 years after the procedure, About 80% of them are cancer-free and do not need a follow-up procedure. And when we think about if focal therapy actually doesn't work the first time, then what do we have as a possible follow-up? And those things would be, people are generally considered to be still candidates for surgery or radiation if the focal therapy doesn't work on the first or second treatment. So what do some of the trial results say? This trial is a really large IRE trial, or irreversible electroporation trial, where they took 121 men, performed irreversible electroporation, and then did a biopsy on them at 1 year afterwards. So 105 men came back for the biopsy, 14 men did not. And what they found is that of those 105 men that came back for the biopsy, 86 did not have prostate cancer at all in the ablation field. Of the 86, of the people that did have cancer, 15 had lower intermediate risk and 6 had higher risk disease in the ablation site. Thinking at a functional perspective, these men that had high erectile function status before the procedure were able to maintain that afterwards. So this table just shows the IIEF, which is a standard formula that we use to calculate erectile function, and found that there's a small dip at 1 month afterwards, but then men typically recover with maybe a 5 to 10% decrease in overall erectile function, but are able to continue to have meaningful intercourse. The next trial is a relatively new trial. It's called a HIFU trial. This was done in Paris, and if you want to come back and kind of look through this inclusion criteria and whatnot, you can feel free to pause. But men were basically randomized to get either high-intensity focused ultrasound or radical prostatectomy. The men that chose HIFU tended to be older than the men that chose radical prostatectomy. And when controlling for all the variables, the outcome that they looked at was whether or not after your initial treatment did you need anything in follow-up. So did you need follow-up radiation or surgery or whatnot? And what they found is that between radical prostatectomy and HIFU, both groups needed similar rates of salvage treatment. So meaning that the prostatectomy line is in red, the HIFU line is in blue. Those lines are essentially overlapping, in my book when I read this, but the general consensus is that it's very similar salvage treatment-free survival rates or similar success rates between the two. This trial looked at roughly 1,300 men over 15 years that got treated in the UK. Similar characteristics where most men were Gleason 3+4 disease, or what we call grade group 2. And what we find is that the strong data in this study was at 5 years. And at 5 years, there was about an 80% treatment or salvage treatment-free survival rate. So what that means is that at 5 years, 80% of men needed nothing further, and 20% of men had to move on towards either surgery or radiation. This study just mapped men between prostatectomy and HIFU and looked for a propensity score matched. Again, looking at failure-free survival, so the need for ongoing therapies or the need to move on to an adjuvant therapy or salvage therapy. Similar rates, statistically similar rates between prostatectomy and HIFU. And the strength in this study was really kind of about to 5 years, and then after that, the numbers, the follow-up starts to drop off. And then more specifically, kind of from a functional status, this study looked at patients' erectile function after focal therapy, and found, what the other studies have shown as well, that at 1 month, 1 to 3 months, there's a dip in overall erectile function, and then that number will typically start to kind of trend back towards your baseline at 6 to 12 months out. And so that's the results that we see listed in this trial here, where the IIEF score drops for a period of 3 months after the procedure. And then as you move forward in time, that number will typically start to move back up towards where you were previously. So in summary, focal therapy has good short-term data that demonstrates for men that have unilateral prostate cancer that is defined on the MRI, ideally grade group 2 disease, focal therapy works, and it works well. For men outside that criteria, I think it's worth a discussion. For men that come into our practice here that get this done after your initial ablation or treatment, we would follow you up with an MRI at 1 year afterwards, and then a biopsy, really no matter what. And then in that interval, we're following with PSA tests. If your results at 1 year show no cancer left in the prostate and the MRI looks favorable, then the follow-up after that would be a discussion of ongoing active surveillance, PSA surveillance, or MRI surveillance, just based on overall risk factors. I hope that this was helpful to clear up some questions today. Thanks so much for joining.